Welcome back. Let's walk through a real world example that ties many of these concepts together. We're dispatched to a bus station for a psychiatric disturbance. The patient is a 61-year-old homeless man, known to us from prior calls. He has schizophrenia and often stops taking his meds. On arrival, we find him in obvious distress. He's yelling that there are demons in my chest and pleading for help. At first glance, this sounds like pure hallucination or delusion, a classic psychotic symptom. However, we immediately notice some red flags that suggest there might be more going on. He's sweating profusely, breathing hard, and clutching his chest. Those could be signs of anxiety, but they're also very much signs of a possible cardiac event or other medical issue. Given his history, it would be easy to assume this is just another psych call where he's off his meds and seeing things. But our crew wisely recalls that even patients with schizophrenia can have real medical emergencies, heart attacks, asthma, injuries, etc., and we must assess for those. We ensure scene safety. In this case, it's a public space, and police are already there because he was causing a scene, so we feel okay to approach. One of us starts talking to him calmly. What's going on, John? You have pain in your chest? Trying to decipher the demon's complaint. We acknowledge that he's feeling something very frightening. Meanwhile, the other medic subtly checks his pulse and blood pressure. His pulse is racing and BP is high. We decide to get him on the monitor. This requires some finesse. Sticking ECG electrodes on someone who is psychotic can be tricky, but by explaining, we're going to check your heart because you said your chest hurts, and maybe even framing it as looking for the demons. Sometimes I'll go along a bit. Let's see if we can find what those demons are up to in there. We gain just enough cooperation. Lo and behold, the ECG shows ST elevations. He's likely having a myocardial infarction, heart attack. In that moment, the plan shifts. This is a time-sensitive medical emergency. We still have to keep the patient calm because if he panics more, it could worsen his cardiac workload or he might become combative and make treatment impossible. So we do two things in parallel: treat the cardiac issue, oxygen, aspirin, maybe even nitroglycerin if protocols allow and BP permits, and continue therapeutic communication to keep him as settled as possible. We tell him his heart is sick and we need to go to the hospital to get the demons, really the blocked artery, out. By aligning our medical intervention with the patient's own framework, we're going to help get rid of those demons. He actually becomes more compliant. En route to the hospital, we alert them that we have a cardiac patient who's also schizophrenic and agitated. They assemble both cardiology and psych resources. Indeed, at the hospital, they confirm he's having a MI. He goes to the cath lab, gets the blockage opened, and is treated with antipsychotics after his procedure to address the psychosis, since he had been off his meds for a few weeks. He survives and recovers. Now imagine if we had just sedated him for being combative and didn't address his chest pain. The outcome could have been fatal. Or if we'd thought he's just hallucinating and not done an ECG right away, we might have missed that crucial window for treating a heart attack. The big take home from this case is always assess medical needs even in psychiatric seeming situations. Don't let the label psych patient blind you to vital signs and physical exam. Also, our approach to communication was key. By not dismissing his complaint, demons, and instead interpreting it in a medical way, we were able to bridge the gap between his reality and ours. We didn't say there are no demons, sit still. We said, we'll help you with those demons, just let us check your heart. That kept him engaged and calm enough to let us do our work. It's a great example of meeting the patient where they are mentally to achieve the cooperation needed for care. This scenario, though dramatic, is not one of a kind. Many patients with serious mental illness die early from untreated medical conditions, partly because their symptoms can mask or complicate evaluation. As EMS, we have to be detectives and caregivers at the same time. In this case, a thoughtful approach saved a life. As we wrap up, let's summarize the key points from this session. Don't miss the medical. No matter how certain you are that a patient is just psych, always do your due diligence medically. Check their vitals, blood sugar, consider injuries or intoxication. This protects the patient and you. The last thing you want is to chalk something up to schizophrenia when it was a head injury or a poisoning. Our case of the demons in the chest heart attack illustrated that vividly. So, stay curious and rule out those organic causes. Scene safety, always. These calls can be unpredictable. Take that extra moment to secure the scene. We discussed keeping distance, being mindful of weapons, using law enforcement help. If the scene isn't safe, make it safe or wait until it is. Remember, if you get hurt, you can't help the patient and you've now created an additional emergency. So wear your seatbelt, figuratively speaking, by keeping safety as your top priority. Communication is key. How you talk to a patient in crisis can dramatically alter the trajectory of the call. A little empathy goes a long way. The patient's reality might be warped by their disorder, but their feelings, fear, anger, confusion, are very real. Show them you care and are there to help, not to judge or harm. Use simple language, speak slowly, and reassure them. Often you'll find that once the patient feels heard and not threatened, they'll begin to calm down or at least pause long enough to let you intervene. Verbal de escalation over brute force. We have tools like restraints and sedatives, but those come with risks and should be last resorts. Whenever possible, try to talk the patient down. We talked about techniques, respecting personal space, allowing them some choice, setting gentle limits, and generally just giving them time to regain control. Most people, if they don't feel cornered and if they feel someone is listening, will not continue to escalate to violence. There will be exceptions, of course, but even in those cases, your verbal efforts are never wasted. They can make the difference between a minor struggle and a major fight. If you do have to restrain or use force, you've already laid a foundation by communicating, and you'll continue to talk the patient through it. Legal and ethical awareness. Know when you're allowed, even obligated, to override a patient's refusal. It's a heavy responsibility to take away someone's autonomy, so it should never be done lightly. But if a patient's mental state renders them incapable of making safe decisions, you have both the legal backing and the moral duty to get them help. That might mean involving police for a psych hold, or just documenting that the patient lacked capacity, and you acted in their best interest. Always follow protocol and law to the letter in these scenarios because they can be legally sensitive. And document, document, document. It's part of our job, and it ensures everyone understands what happened and why. Compassion and professionalism. Last but not least, approach these cases with compassion. It's true, psychiatric calls can test our patients, especially if it's a repeat patient or someone whose behavior is challenging. But these individuals are suffering from an illness, just as real as diabetes or asthma. We have an opportunity in EMS to be a calming, helping presence in what may be the worst day of someone's life. I've seen patients who were extremely agitated actually thank EMS later because we treated them with kindness when they were at their lowest. It can be rewarding to know you made a humane difference, even if the patient doesn't immediately recognize it. And from a practical standpoint, maintaining professionalism, no matter how the patient behaves, protects you. It's the right thing to do, and it also usually leads to better outcomes in the moment. In conclusion, dealing with thought disorders in the field is challenging but manageable with the right approach. Ensure safety, connect with the patient through calm communication, assess thoroughly, and know when to invoke additional help, be it medical or legal. Your presence and approach can truly influence whether a chaotic scene turns into a safe transport or a dangerous confrontation. By applying these principles, you'll not only ensure safety for your team and the patient, but ensure they get the help that is needed. Thank you for joining me and stay safe out there.